Good afternoon, everyone, and welcome to our HHS virtual town hall for today, January the 14th. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. We have a number of updates on issues that are evolving in our pandemic response, and we'll cover those with various presenters. And we'll leave time at the end for questions. And at that time, I'll come back and moderate, and then we'll also close with some celebrations. So to kick things off, over to Rob McIsaac, our President and CEO, for some introductory remarks. Rob, to you.
Yeah, thanks very much, Aaron. Good afternoon, everyone. Thanks very much for joining the town hall today, as always. So today we are going to get an update on pandemic response planning from Sharon Pearson. We are going to have our usual update on the epidemiology of the virus from Dr. Mertz. Dr. Fiona Smale will provide us with some information about vaccines, and Les Gauthier will share an update about vaccine distribution and administration. As always, we'll have time for Q&A, as Aaron said, at the end. Before I turn things over to our other speakers, maybe I could share a few highlights from my perspective. I think we've made some amazing progress in the past several weeks. We anticipate that by early next week, Public Health will have finished vaccinating staff and residents of long-term care and high-risk retirement homes across the whole of the city. I expect we will have also completed vaccinating the most at-risk staff and physicians at HHS by that time as well. The rollout of the vaccines provides us all with some hope, and we're grateful for everyone who is working to expedite supply chains and get vaccines into people's arms as quickly as possible. Having said that, if the provincial modeling being shared at the moment becomes a reality, our greatest challenges are in the weeks immediately ahead. Overall, hospital occupancy remains high, including in critical care. We are surpassing peaks seen in the initial wave of the pandemic, and we're continuing to see increases in the number of cases, hospitalizations, and outbreaks. We are continuing to work closely with local, regional, and provincial structures and government to respond to the pandemic and optimize capacity for care. Our goal is to ensure that no one hospital, no one site becomes overwhelmed with COVID patients. To relieve the surge of critical care patients being treated across the GTA, which is particularly hard hit, our region has recently accepted several ICU level 3 patients. Those patients have gone to nearby hospitals over the past couple of days, and I think we can anticipate that those transfers out of the GTA and into Hamilton will continue to happen in the coming weeks. These transfers take into account our regional census, what's happening to us locally. They are done in a reasonably collaborative manner. So Sharon will provide more information about how we're working with our partners to support access to care. As always, I'll just say thanks to everybody for their ongoing commitment and dedication to our patients and to your colleagues. We have a lot to be proud of, I think, in terms of how we're serving our community and our province, and I'm very grateful to all of you for that. So I'm going to now turn things over to Sharon.
Great. Thank you, Rob, and good afternoon, everyone. Just before I talk a little bit about the pandemic response planning in regards to how we're doing at the sites today, our COVID volumes, as Rob mentioned, continue to rise, and I know everyone's well aware of that and well surpassed our volumes we saw in wave 1, and there is around 80 COVID positive patients across our HH sites today. The outbreaks, we continue to be challenged with the outbreaks, as do many of our peers. There's currently 6 outbreaks under management right now, spread across the sites that you see there on the screen. And again, I direct you to the hub for any of the most recent updates regarding the status of the outbreaks and the management processes in place. Certainly, we're feeling the escalating pressures from the impacts of the outbreaks, the blocked beds that result in more ED pressures and impact our system partners vis-a-vis delays in the ED for EMS. So we know that it's very challenging in the work areas right now to manage in the current situation. Equally, our peers in the community are experiencing their own pressures. There's about 16 outbreaks right now spread across the long-term care homes and retirement homes in Hamilton. And that's a substantive number of outbreaks. We do know to Niagara, they're facing even more than that, which is a very concerning and sad situation for the system right now. If we could go to the next slide. In terms of the response system and the tiered planning, and really the slides don't do justice to so all of the work that's going on, these different levels and efforts to manage the pressures that are occurring across the different sectors. But certainly the provincial direction, which we all receive in the media as well, is that we need to maximize whatever capacity we have in the sectors right now. From a hospital perspective, we are maintaining that 15% surge capacity. And that's about 150 beds within our system that we need to have available for COVID capacity. And we have about half of that filled right now. And we continue to evolve our strategies to create additional capacity. Lots of focus on critical care right now as we see those very substantive pressures in the GTA. And as Rob mentioned, being part of the provincial planning in terms of load balancing of critical care patients to ensure that patients have access and not one hospital is struggling to manage the burden of the volume of patients. We're doing a lot of our own internal planning right now related to our critical care resources and how best we can optimize the resources we have across the sites, but also ensure that we are not impacting our urgent scheduled care as well. From a regional planning perspective, HHS remains one of the 4 designated COVID sites, and we work closely with Joseph Brant and Niagara and St. Joe's in helping the province with the system management of the COVID patients. There's a number of different tables that are trying to plan across the region versus across the hospitals from a capacity perspective. Another group looking at surgical and procedural work, and another looking specifically at critical care and how we join the regions together, and then how we join the regions across the province. And then lastly, we referenced this last week in that the Regional Pandemic Response Unit, or the PRU, in Joe Brant did open last week, and HHS is looking and will assess for appropriate patients to transfer to the Pandemic Response Unit. And then if we can go to the next slide. We have our own internal, and many of you may be involved in that planning as well. We have a number of task forces, including one looking at ambulatory care, another looking at capacity, another looking at transitions. And I think by the nomenclature, you can appreciate what the areas of focus are as we look at, do we have the appropriate levels of activity and supports within those different areas. Lots of bed map adjustments are in progress. We've seen some substantive adjustments at the Jaravinsky site and the establishment of the outbreak unit on F5. And as I referred to, we are looking at our critical care resources as well, and really looking at how best we use the beds across the system right now to manage activity. The planning, of course, is daily, it's hourly. We're doing as much as we can to anticipate and forecast the effects of COVID and what they will have on HHS and our respective sites. So as we know more, we'll certainly share those details and keep those working in the units in the support areas as informed as we can about our plans related to COVID. So again, advise you to keep watching the hub for those updates. Happy to take questions in the question and answer period, but I'll hand it back over to Aaron.
Thanks very much, Sharon. So next up on our agenda, we're going to hand things over to Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control. Dominic, for a bit of an update as to where we sit, over to you.
Yeah, thanks, Aaron. As usual, I first show you the local EPI. Again, map of Canada. Let's start with Ontario, 168. So very stable, I would say, at this point of time. No significant increase, but no significant decrease either. Our RT value is at 0.99, which means, well, we have been relatively stable over the last week. What you can see is that Saskatchewan is getting our new, or becoming our new province with the highest numbers, or at least on track to, with 192, and quite a high RT value there. So expectation is that they will continue to rise, while Quebec, with currently the most cases, 203 per 100,000 per week, is actually declining as well. Manitoba, which was one of the hotspots in fall, is back to 85, similar ballpark as BC with 77. So certainly in a better spot than we currently are in Ontario. New Brunswick continues to increase, but still at low levels, currently at 20, but with a 20% increase over the last 5 days. Next slide. Here you can see the epi curve again with the blue arrow, which is our holiday break. I would say over the last 4 days, things look better again. It looks like we have plateaued, and that this post-holiday peak that we've observed may not result, I would say, in a continuing increase of cases, but still too early to call and to be sure that we are after the peak now, but things certainly look better than a week ago. Next slide. In terms of hospital admissions, however, not so, and I think we've all learned or know by now that hospital admissions is lacking behind number of cases, and here you see a continuing increase into this week with much higher numbers, that's province-wide, than we would have had at peak during wave 1. When you're looking at ICU admissions, which are those dark red small bars embedded into the larger bars, it's not much higher than it had been during the early peak for ICU admissions back in wave 1, but it's been higher, and you can also see that the trend continues to increase here. Next slide. The Hamilton view, very similar to the provincial view, maybe even a little bit more optimistic at this point. Again, the blue arrow for the dip that we had in testing, most likely during the holiday break. Then we had the post-holiday peak, and now we seem to be back at around 100 cases per day, which is where we've been sitting before the holiday. So hopefully we get back at least to those pre-holiday numbers and then continue to decline. Next slide. In terms of hospital admissions, again, similar picture as for the province. We see a continuing increase in number of COVID patients admitted, much higher by now than during wave 1. And also to remind people, the peak that we had during wave 1 wasn't necessarily because of the number of people who actually required acute care. The peak was mostly the rostering that needed to be decanted. So much higher numbers here, reflective of what's going on in our region, but to an increasing amount. And I think that something that might remain true for the time to come, with admitting patients from outside of our region as well. Next slide. This is the modeling, or some of the modeling that has been shown on Monday, done by the province. It doesn't help us an awful lot because we don't know whether we will be 0%, 1, 3, 5, or 7% increase. The hope is, of course, that it will be 0% or in fact decreases. But you can see that, well, obviously, if there's a 0% increase, we will continue to be in that 3,500 range of new cases per day. With a consistent 7% increase, that would mean with the exponential growth by mid-February that we would be sitting at 40,000 or more than 40,000. So it will more than increase by a factor of 10. But yeah, that would be really a worst case scenario, and I'm very optimistic that we can prevent this from happening. Next slide. In terms of ICU beds, again, if you're looking at the 0% prediction, you would still expect an increase over the next week or two, again, because the use of or the need for ICU beds lags behind the case numbers. And again, obviously, if we end up with a 7% scenario, that wouldn't be sustainable or feasible for our healthcare system to sustain with a need for 3,000 ICU beds on a given day for COVID patients. Next slide. Handing over to Dr. Fiona Smale here, who's, I would say, our infectious diseases face for the vaccines. And we asked her to present on the vaccines and cover some of the most common questions that we are being asked. Thank you.
Thank you, Dominic. So there have been 2 COVID vaccines that have been licensed by Health Canada for emergency use. Both of these are what we call messenger RNA vaccines. And basically, with the injection of a small part of the COVID spike protein viral RNA, the body really is tricked into making a protective immune response to the virus. And this is a new technology for making vaccines. There have to date been 2 very large studies that have been completed and published that we've been able to really review and analyze very thoroughly. The Pfizer vaccine had a total of 44,000 participants. These were randomized trials. The Moderna vaccine, 30,000. And these studies have shown us that to date, after completing the recommended 2-dose series of the vaccine, protection against COVID infection was as high as 94 to 95%, which really are very significant protection rates. Next slide. We've had the question, is there any antibody testing that should be done after vaccination to measure immunity? And there is nothing that is currently employed in the routine rollout of the vaccine. As with most vaccines, like the flu vaccine, there is just an assumption that the vaccine has worked. And knowing that the rates are 94 to 95%, I think we can be very confident that the greatest probability is that somebody would have developed immunity after vaccination. As far as we know, people are likely to have immunity to COVID for 3 to 6 months after an infection, but we're still learning exactly how this compares with the immunity after vaccination. One of the questions we often get is, should I have the vaccine if indeed I have had a diagnosis of COVID infection? And while we're generally recommending there's no harm in getting vaccinated if you previously have had an infection, we would think that you could safely wait for a few months and not go to the front of the line and maybe wait until those with the highest risk of COVID have actually been vaccinated. The COVID vaccine is safe. Millions of people actually have been vaccinated so far, both in the clinical studies as well as in the worldwide rollout. Most people tolerate the vaccine really well. There can be some discomfort at the vaccination site, and some people will develop some mild symptoms such as a little bit of fatigue and or headache. Serious side effects are really, really uncommon. Anaphylactic reactions, which many people with a history of allergy are concerned about, have been estimated to occur at the rate of 10 per million, which really is very, very, very low. So I think that what we've got here is a very effective vaccine and a very safe vaccine. And indeed, we're very fortunate to be in this situation at this stage. So Erin, I'll stop there and move on to the next presentation.
Wonderful. Thanks so much, Dr. Smale. We may come back to you in the Q&A. as I know there are many questions, a few already in the Q&A box about this topic. So now for really an operational update about our vaccine rollout and how we're doing in that regard. I'll call up Leslie Gauthier, our VP of Clinical Support Services and Surgery. Leslie, over to you.
Thanks, Aaron, and good morning, everyone, good afternoon. So there's been lots of really positive coverage in the media this week. The Pfizer vaccine clinic, which is at 293 Wellington, has been up. We've doing like almost 1,000 clients a day. And really important is that vaccine has been taken out to long-term care in high-risk retirement homes, and public health is really working very hard and been very successful to get a number of the clients and their staff also vaccinated. We are continuing within the 293 clinic, which we're calling the Fix Clinic, to vaccinate people who are in sequence 1. A reminder to everyone that sequence 1 is our highest organizational risk between HHS and St. Joe's with respect to the staff in the emergency ICUs and working on the COVID units or high risk of AGMPs. That group continues to be our focus, and we're really helpful. We're going to get, or hopeful that we'll get through this group coming into this weekend. And a significant change that has been formalized this week is across both organizations, learners are now included in the sequencing framework, and our learners, both physician and non-physicians, are to identify themselves to the unit where they're placed. So a nursing student in the emergency department would be sequenced in group 1. A physiotherapist student working on an inpatient surgical unit would be sequenced to group 3. If I can have the next slide, please. Some key messages from the actual clinic. Most important is that vaccination appointment is a scarce resource, and we want to be as effective as we can of using the capacity in the clinic. So if for any reason you can't attend your visit, the email link is there. It's easy to remember. Just type in cancel and you'll get cancelvac@hhs.ca. We have a process in place if we have capacity every day that we're calling out to the highest risk teams. So please let us know. And in that, if you happen to be self-isolating, either for a personal contact or professionally because of your exposures at work, you cannot get the vaccine. So super important that you notify at CancelVac. Michelle, my colleague, spoke earlier this week, just a general reminder to people around code and conduct when you're booking appointments coming to the clinic cannot accommodate walk-ins. The staff who are actually calling out to book these appointments, many of them are volunteers who are doing it outside of their job, and we just need everyone's cooperation to be as respectful as possible during the process of booking. When you're coming over to clinic, as I said, we're looking to get really high numbers, 500 to 1,000 people a day through. We'll be much more efficient if you can print off and bring a signed copy of the consent. With that also gives you time in a quiet environment at your own pace to read through the consent and be comfortable. If you have any personal questions around your health, we're asking that you sort through that with your primary care physicians or specialists before you come to the clinic. And gentle reminders, bring your health card, bring your hospital ID, and just to remind everyone that our focus right now is still to get vaccines in the arms of our team members who are most at risk. So I think with that, I'm ready to hand it back over to Aaron.
Thanks very much, Leslie. As is normally the case in this, as our efforts in the pandemic proceed, I have a daunting task ahead of me managing the volume of questions that have come in, but we'll do our very best. I just wanted to mention at the outset that if we don't get to your question, we'll try to follow up one-on-one and post something to the hub where we can do so. Dr. Smale, I see you come on video. Maybe I could pose, there's a couple questions in here about the vaccine. I'm going to lump a couple of them together. Really around the the duration of immunity that one might expect from the vaccination? And then I guess connected to that, how might we change our isolation protocols? And maybe Dr. Mertz wants to weigh in there, given the effect of the vaccine. So when an exposure occurs, how does that change how we think about someone's risk that they pose to others?
Well, thank you for the question. The issue about how long does the immunity last is really a very important one. And as you can appreciate, we've only really been able to study these vaccines for 6 months plus at the longest. So we really don't have the answer to the duration of the immunity. These are, again, going to be some of the important research studies that will go forward. My sense would be, given the nature of the type of vaccine, that there may be some requirement for a booster at some point. But this is just a hypothesis at the moment, and we're going to really have to study this so that we can really make the appropriate recommendations. Because I think, as the question asks, this is not going to go away in 6 months.
Very good. And Leslie, there's a couple of questions more practically, I think, about the vaccine rollout, specifically about the proportion of staff that would be in sequence groups 1, 2, 3, and 4, and as well then sort of the relative handing out of the Pfizer versus Moderna vaccine. Will it shift over time as we proceed through those groups? Can you give us a bit of an insight as to how we're managing the volume of people that need the vaccine and who gets which one as we are dependent on supply?
Sure. So I'll answer the hardest question first, and that is the number of people in each sequence group. So when we started this planning, remember, it happened super fast, and we acknowledged up front we knew there would be some bumps in the process. We thought we would see about 25% of our teams in group 1, 50% in group 3, and then the last quarter divided by 2 and 4. So 3 would be our largest volumes, 1 would be second, and then 2 and 4. What we are seeing across both organizations is a higher than anticipated number of people that believe they belong in group 1. And the question we're asking everyone to ask themselves is, when you think of your own risk of coming in contact with COVID, where do you think your risk is compared to the teams in ED or working on the COVID unit? And if your risk is not the same risk as the team that are working on our COVID units, you most likely belong in group 2 or group 3. So we are doing some work to try and understand where people might have over-sequenced themselves. We're working with HR and our physician leaders to try and understand that today. But right now, it's still looking like we'll get through the majority of our group 1s in very short order. So yes, the process had a little bit of flaw to it, but we've been super successful of getting people, and the majority of the right people, vaccinated. The second question is, the Pfizer vaccine was focused to the fixed clinic because of all of the concerns over the fragility of the vaccine and moving it. As of tomorrow, the Moderna vaccine is arriving in the city, and that vaccine is arriving in the hands of our public health colleagues. So we've been using Pfizer vaccine this week to help vaccinate in long-term care. We're going to continue to have the conversations of which patient populations, or client populations, which vaccine. But right now, we're still trying to keep it simple. Pfizer, you need a second dose at 21 days, and Moderna, it's 28 days. So both the vaccines are not interchangeable, and we need to just continue to try and keep one group focused to hospital, which is Pfizer. Moderna will transition tomorrow to focus to community and long-term care. And then we have a table to have discussions in the city around, do we reach a point where we could use either vaccine for either patient or either client groups? We're not quite there yet.
It's a very complex
So
situation.
it's probably clear as mud.
Totally supply dependent, and we'll certainly have to keep everyone apprised through this forum as we move forward. There's a number of questions that have come in about where the people can find a consent form. So a very practical detail. I'm not sure if you can provide some insight on that, or maybe we need to post that on the hub.
It is there. It's in. There's a link to the consent and all the information your colleagues have put out for people.
Wonderful. So all in one place on the hub, you can go there and follow the links to get the consent form. Okay. Questions here about, and this has come up as well. Two questions, Leslie, maybe for you. One, are all the appointments being scheduled by phone? Is the first.
Yes, so people are calling out. So the phone number you provide when you signed up is super important. They're calling out. It'll be a no caller ID call. So just if you have a habit of not answering those, you might want to rethink that. And if there is no answer or it goes to voicemail, your name will go back into the randomization tool to be pulled by the next person who's pulling out of the general lottery. There's no ability to leave messages and return calls. Way too many people we're trying to manage right now to get booked in.
Got you. In terms of the efforts to book those appointments, I know every webinar we have someone who asks if they can help. Where are we at in terms of the support required to book those appointments? Are we running at full throttle?
Yeah, so there is a longer term plan that we can actually stabilize the staffing model, that we have enough clerical support to do those calls. Right now, if people are interested to volunteer, I'm going to direct you to Brian Hairchuk, or Brad Elms, who have been coordinating the scheduling of volunteers to help do calls. I think we're pretty hopeful that we're going to get to a point where we can be less reliant on volunteers to do the bookings.
Okay, good stuff. I do have someone with a hand raised here in our participants box. I want to be respectful of those that might have a question. I'm Chris Hillis here. So Chris, you can go ahead with your question, please. Need to unmute though. Okay, maybe while Chris gets to the unmute, I also have Ingrid McKee. Ingrid, if you wanted to go ahead with your question. Again, you'll have to unmute. Maybe one of our panel, maybe someone in charge of the webinar can help with the unmuting function. It seems 2 in a row now unable. Is that something that someone on our technical side can assist with for either Ingrid or Chris? Okay, we have another question. I think you've shortened your name, BD. If you have your hand up and wanted to go ahead, maybe you can see if your question will come through. Okay, seems we're having some technical difficulty with the hand raising. I'll ask my colleagues in charge of the webinar to take a look at that. I do see some questions here, a lot of questions about the effectiveness of the vaccine in terms of first dose and then delaying a second dose, et cetera. Much of that has been answered in the Hub's Q&A section, but maybe Dr. Smail, you could comment on, where are we at in understanding we're supply dependent? What are some of the decisions you think might be in front of us as it relates to first and second doses and the efficiency of the vaccine?
Well, as you probably know, this is an area where there are lots of questions being asked. Because very few people only got one dose, it's hard to estimate the effect of a single dose and how long that protection will last. It's probably high, at least to begin with, and that's why there has been this discussion, if there is a vaccine shortage, to give more people one dose rather than reserving those second dose as the best way of really protecting the whole community and transmission. transmission. And there have been some recommendations coming out of NACI, which is the National Association Advisory Committee for Immunizations, that it may be reasonable if there is a critical vaccine shortage to delay the second dose. What we're planning at the moment, however, is that we do have sufficient supply, and so our intention, at least locally, is to proceed with the 2 doses as recommended, and for the Pfizer dose vaccine, that's within 3 weeks.
Erin, if I can just add to Fiona's comment, people who have been contacted for their appointments, they'll know when we book your first appointment, we book your 21-day out appointment. So the 2 appointments are being booked together at the same time.
I see. And in terms of our timing and sequencing, Leslie, is there now, like, when do you think it might be reasonable to say we would move from staff into patients and then to the general population? I know that's totally a guessing game at this point, but what's your sense of it being involved on the inside? Like, what, it could change in a heartbeat, but what are you expecting?
So you want the inside scoop. I think the most important thing that everyone at HHS is reminded of is there is unanimous agreement that the most important group that get vaccinated first are our long-term care residents and the staff there. So in terms of patient populations, as we start to reach out to patients at HHS, we're just going to start work on how can we reach out to long-term care patients within our facilities. So I think that will be the first signal that people will see we're starting to reach out to patients. The work to be done is we have a sequencing framework for the hospital. There is a sequencing framework being worked through for the community. And in between is an interface. We have hospital teams that are going out to work in the community. We have community teams that come in to support the hospital or keep our patients out. And that's going to be the next big piece of work we start to work through is those interfaces. So short answer, long-term care ALC patients will be the first, and I think we should start to be seeing some of that work maybe as early as next week. We should start to be seeing some work on the interfaces of where we work with the community to support each other. I think we'll put some clarity to that out by next week. And then there's an awful lot of people to be vaccinated between the community and the hospital. It's going to be, how do we start to sequence that work together?
Understood. Shifting gears a little bit. So I'm told, I'll try again just for Ingrid or BD. I'm told that you would get a message sent to you asking you to unmute, which you would then have to click. I'll try again in the order in which you raised your hand. So Ingrid, I'll send that message now and see if you'd like to unmute or if that's possible to ask your question. Go ahead and try now. No, not possible. Maybe you raised it in error. BD, I'll try you.
Sorry, my question was answered already. Thank you.
Thank you very much. Okay, well, we know that technically speaking, we're doing the right thing. So thank you for replying. Okay, so just switching gears slightly here on the topics at hand, I did see a question about visiting policy in relation to the lockdown. Don't think Kirsten Kroll could join us today, but maybe Sharon or Dominic, if you wanted to offer some perspective on, like, when might is it appropriate to reconsider visiting policy? I know our primary consideration is always to make sure that people can connect in some measure with their families, given the significance and importance to their well-being and care. But does the recent announcement by the Premier change that prioritization in our view?
We discussed this morning. Kristen was there as well. She will probably be the best person to address the question, but I can try to take it here. We had conversation with public health as well around whether this should or should not affect our visitor policy. And our read of the provincial guidance is that leaving your house to provide support or essential care is allowed. And our current wording is not that we allow visitors, we allow essential caregivers to come in. And from our perspective, that should continue to happen. We don't have any evidence that it's essential caregivers bringing us into outbreaks. We haven't had that situation where we felt like, okay, without essential caregivers, we wouldn't be in this mess at this point of time. So it doesn't seem to add a large amount of risk, knowing that, yeah, it would be wrong to say it's zero risk. Every individual walking into our institutions at some level of risk by bringing the risk in from out in the community. And the other piece I think we discussed repeatedly here is really the patient-centered care as being one of our main goals. To provide best possible care involves essential caregivers and loved ones. And we want to stick to that to the best we can. During outbreaks, yes, we will, in particular with large outbreaks, we will continue to reduce visitation to the absolute minimum, which is only for compassionate reasons. But when we consider the unit safe for visitors, we will or the recommendation at this point is to continue to allow that. And also going back to what I've just shown in terms of risks, it doesn't look like we are in a larger risk at this point of time than we had been before the holidays. So the fact that the province sort of switched gears doesn't necessarily mean that the average person brings in a higher risk than a few weeks ago.
Gotcha. I guess, Sharon, anything you wish to add?
No, Aaron, I think Dominic did a great job of really showing the thoughtful review that's being done when we look at visitation and really balancing the risk and looking at the value of the visitation to the patients as well. And we all heard about the harm that was done in wave 1 with visitation policies. So I wouldn't add more than that. Thanks.
And Dominic, just a consideration. I don't think we got to it with Dr. Smale earlier, but the potential change in isolation protocols as we move forward. What might you anticipate as more and more of our workforce becomes vaccinated? How would we think differently about what we might guide someone to do once they've been involved in an exposure?
These are the conversations that will start very soon. The only change that we made at this point of time is once you are fully vaccinated, which means that you have had both of your shots, and 1 week after that, when you have maximum protection, that we no longer require someone who worked, for example, in a long-term care facility in outbreak to stay home for 7 days until they are allowed to come back. Many of those decisions around policy after exposures really hinge on to what extent the vaccine is able to prevent you from getting infected. Now, we know we are at 95% to prevent you from getting sick from the virus. That doesn't mean that it prevents 95% of infections, and you may still be able to transmit the virus. We don't have great evidence yet how good that sterilizing immunity, how we refer to that, or that's the term we use, actually is. It's probably more than 50% based on some subgroup analysis that had been done in vaccine studies, but the studies had not been laid out to really look into that as one of the primary outcomes. So we will learn. And I think the other piece will be, we need to align with public health in those decisions, right? We cannot say, if you're vaccinated and had an exposure in hospital, you're good to go, while public health for the same exposure in the community would say, no, you self-isolate for 14 days. So I expect there will be guidance coming down from the province as well. We have some wiggle room with self-isolation, but come to work isolation type of approaches, which is something we can consider doing. So those conversations will be starting, and we will need to look into that evidence again, and we'll make our own experience along the way.
One of the other questions in here is about I know we've talked a lot about how the incidence in the community then sort of drives a proportionate number of staff that are in quarantine, and the impact of outbreaks across the community, including at HHS, is in a lot of ways a correlation of the prevalence of COVID-19 in the community. The question in the Q&A forum is about whether PPE effectiveness might be called into question as we see an increasing number of staff in quarantine or outbreaks. Can you comment at all about how the scientific, like looking at PPE as a rates increase, has thinking changed at all?
Now, nothing has really changed, and most cases, we just looked into that, most cases that are in self-isolation or because of exposures or those who got the infection are still community acquired and not hospital acquired, despite all the outbreaks we have had. I saw the one questions around, should it be level 2 masks instead of level 1 masks? And I think that's a Pandora's box that we opened here at HHS by being very transparent in introducing what a level 1, 2, 3 mask is. When you ask other hospitals, they may not even know what they are using, and they don't necessarily discriminate, they just use what they have. Is there any evidence that a level 2 mask is better than a level 1 mask? No. Because of the ask from staff, we started to provide level 2 masks on certain units and during outbreaks, but it's not because we feel or have any evidence that those are better. And it's typically those soft calls that bring us into trouble as well, because then suddenly we have to justify why isn't everyone in level 2 masks. So no, evidence-wise, there's no differences. What we are struggling with is a very high burden that's coming in from outside, through staff, sometimes through patients that are going unidentified because they are still incubating when they come in. And then you have the transmission, most likely due to micro breaches in our PPE or in our behavior. We have had outbreaks on or continuing spread in areas where we had level 2 masks, where we had universal face shields. That's another common ask. Well, we just need eye protection. No, it's not as simple either. So that's why we are currently sticking to what we have in terms of PPE recommendation, which are very well aligned with what the province recommends.
Wonderful, thanks. I did see a few questions in our Q&A about the King West administrative office space. And any impact of the recent lockdown. Offline, I did connect with a couple of people most knowledgeable on that subject who said that currently our process, is physical distancing in that office space when you are required to be there, very minimal traffic at this point. You should be following the guidance in the lockdown mandate, which is that if you can work from home, discuss that with your leader and where possible, do so. However, you have to go to the office. It is not closed. But we should all be observing the physical distancing requirements and following good practice when going there, which I believe also includes at this point in time some screening requirements with the landlord at Jackson Square. So I'm conscious of time. I know there are some questions vaccine related we haven't gotten to, and 2 hands raised in our inbox. Maybe if you could type those questions in the Q&A, we'll do our best to get to those in response. But I want to move us on to our celebrations portion, gratitude and celebrations being such a critical aspect of how we can keep ourselves focused and positive in the darkness of the pandemic. So maybe Rob, you and I can take a moment now to call out some of the celebrations and encourage people. If you'd like to raise your hand, we can call on you to give a shout out live. And if you'd like to type something in the chat forum, then we'll certainly do our best to read that out. Also, panelists, you are welcome to also raise your hand and provide any shout outs that you'd like to all the work that's going on in the organization. So much happening across all of the different topics that we've talked about today, and lots we're celebrating. Sharon, I see you've come on camera.
Yes, thanks, Aaron. And I know we've said this before, but the work of managing these outbreaks across the organization, I know, is inordinate, from the care to the service supports that need to be provided, the multiple bed moves, the different communications. And, I know it's very burdensome on all of the staff. So it is appreciated and it is recognized, the work that's being done in response by everyone to manage and to control the outbreak. So thanks to everyone for all the continued work.
Perfect. Thanks, Sharon.
Yeah, Aaron, I would say on a similar vein, to Sharon and to Les Gillies and to everybody who worked to stabilize Grace Villa. incredible job. Touch wood, things are going well there. So hopefully that continues, but it's amazing, you know, what's been done to date. Really impressive work, and, you know, really important for the residents living in that facility.
A note in our chat forum from Elizabeth, a very smooth process and cheerful staff at the vaccination call center. Thank you in caps for the difficult work at this time.
Aaron, just a quick on that same vein, really, I think we need to thank all those who volunteered for that work to notify people of their appointments. And lots of people got involved with that, and very much appreciate their input. And the feedback has been, it's probably been one of the most enjoyable jobs because people like the good news that gets delivered when they've got an appointment. So thanks to all those people for volunteering.
For sure, for sure.
We do have one in the chat box here. Huge shout out to Pam Westover and Connie Kuhn for their leadership at Grace Villa, and Dr. Tammy Packer.
Perfect. And another one just in now from Bartholomew. We as nurses do our best to record family members coming to visit, and that's hard. Essential caregivers are important in patient-centered care, but the visitors are coming in to see family, to visit. I think that's more of a comment on content we've already covered, but thanks for pointing that out. Also here, a shout out to Brian Herchuk and Lucas Milanovic for their leadership in the vaccine clinic operations.
Yeah, another one, shout out to all those who got the vaccine clinic up and running, and those that are continuing to work the vaccine clinic. Yeah, great, amazing work. And it's gone very smoothly.
Thanks here to Kelly O'Halloran for her team for supporting Grace Villa and other LTC and retirement homes. Thanks to the NRT and crisis response team for their incredible work.
And then another one to HRLMP for their suburb COVID testing. That's actually a great piece of recognition. I think we've done something like 350,000 COVID tests over the past 10 months. So it's been an amazing ramp up to provide this service to the community.
And I didn't have to pay Sasha for this one here. Someone has reached out to express gratitude and appreciation to my colleagues in communications for the wonderful work being done to keep the community connected. Certainly, I'd like to add my voice to that, thanking the team for everything that they're doing. And always a pleasure to be part of these webinars, which I think have evolved into a really great forum to make sure that people stay connected to everything that's happening. So thanks to everyone involved in making these possible. Leslie, you come on camera.
Thank you. So one of the really neat things about working at HHS is that people are comfortable to challenge and have difficult conversations. So with that context, first of all, I'd like to thank Hélène Flagiol, Sarah Kahn, and Fiona Smale, because as people have been coming forward to seek clarification around the sequencing framework, we've had some really, really valuable conversations with teams. So my thank yous twofold to my colleagues who are helping us listen to the concerns of teams. And most importantly is I have a sincere thank you out to everyone who, instead of grumbling and not understanding, they're really seeking to understand and asking us to help them take messages back to their colleagues and their teams. So thank you for the willingness and your openness to ask the question, and then a thank you for engaging in the conversations. It's what makes HHS a pretty cool place to work.
Rob, there's another one here from Patty McEwen. I'd like to celebrate my team, HR operations, who do the work to make sure employee transactions are completed and people are paid appropriately. With all the different initiatives going on, long-term care, satellite health facility. The volume has increased significantly and they've worked long hours to ensure everything is in order. So thanks, Patty, for pointing that out, and thanks to the team that makes sure everybody gets paid on time and accurately. That's great.
Might be time to wrap it up, Aaron.
Yeah, okay. Well, thanks, everyone. Maybe just a reminder to those that had unanswered questions, we'll do our very best to provide a response to you through the hub or directly wherever possible. We also use those questions to inform the content of the next presentation, next virtual town hall. And in the meantime, you can email anything to the hhsnews@hhs.ca inbox. Rob, if you want to close us out, thanks very much.
Yeah, thanks, Aaron. Great job as always. And thanks everybody for attending. I'll just finish by reiterating my gratitude and appreciation for all the hard work and dedication that everybody's doing. These next couple of months, I think, are going to be very challenging, but I do think we're very much, we've started the beginning of the end of this very long ordeal. So we just need to hang in there for a bit longer. So thanks all, and hope you have a great rest of the day and a great rest of the week. Cheers.